get started. I'd like to thank everyone for joining us this morning for the webinar regarding in-person monitoring and returning to that. A couple housekeeping items before I turn it over to today's presenters. We do have a large number of folks registered for this event. We had 326 people registered, and right now we just passed 240. So we know that we have a lot of folks on, and that there may be a lot of questions that come in as we go through this. With that said, if you will be sure to put your questions regarding the content in the Q&A box, that would be helpful. I'll be monitoring those questions as they come in, but we'll wait until the end of this presentation to take a look at answering those questions. We are scheduled until 10, so if by chance we run out of time and don't get all those questions answered, we will be sure to follow up with you. And with that said, I'm going to turn it over to today's presenters. We have Wendy Witzig, Deputy Division Director, and Carrie Williams, our TCM Tax State Lead. So I'll turn it over to them.
Thank you, Hipaa. Good morning, everybody. And I want to start off by giving a sincere thank you to every single direct care professional, support coordinator, and state employee out there that's on the call or not on the call. You've all been intricate in our efforts to deal with this pandemic and have been working nonstop throughout the whole process. And your efforts have been extraordinary, and all that we have done to date to get through these really unprecedented times. It's a tribute to your commitment, your dedication, and the love for the people that we all support. And we certainly could not have accomplished all that has been accomplished without you as a part of our team. So looking back, who would have thought that on March 16th, when the governor instituted the stay-at-home order, we would be here now almost 6 months later? We've learned a lot about the virus and about how to protect ourselves and those we care about from it. But what we know for certain is that there will continue to be change. Information and new best practices are constantly evolving, and we need to learn how to build dynamic programs and systems that can adapt to the changes as they come forward. So the question becomes, how do we move ahead? The virus will be with us for quite some time, and so we know we have to face the challenge and learn how to live with it. We can't hide from it, and we certainly can't avoid it. I think that has been proven time and time again. We have fought for years to move from what used to be a very medical model to one that is focused on the individual, family, and community. So it feels really contradictory and uncomfortable now to talk about our network as a part of the healthcare system. But what we know is that how people live, food security by having enough food to eat, meaningful work, paid and unpaid, and having connections with family and friends has a direct effect on a person's physical, mental, and emotional health. And that is where we come in. This is where you come in. We are an extension of the physical health system, and you're all essential parts of it. So we have to look at ourselves as essential parts of that system. We have been fortunate so far in controlling the spread of the virus in our provider network. Although every death is tragic, we have had only 7 deaths to date resulting from the coronavirus. Realistically, we know that there's going to be more to come. Our goal needs to be that when we have a bad outcome, that we can look in the rearview mirror and say, I did everything that I could. We checked on people to be sure that they were safe and getting good care. We know our providers were implementing best practices to mitigate risk. We talked with each other, families and individuals, when we had concerns about the path. We can't prevent the bad outcomes, but we can certainly do our best to try. And so with that, I'd like to move into what some of those efforts are and just being prepared around our monitoring efforts. Our service providers are required to have written operational guidelines to help them and their staff know how to mitigate risk and to respond to an outbreak. That's not currently a requirement for TCM agencies, although I'm confident that you all probably have guidance in one form or another, either as standalone documents or as a part of a policy or procedure that you've developed to guide your staff and helping them to be prepared to return to the field. So the list here on the screen is it's a list of components that should be considered as you prepare for the workforce to return to the field. It's not all inclusive, and you may have many things to add to it already. So be sure that you have a process in place for your support coordinators to be doing screening, self-screening of themselves before they go out into the field, and preparing and making sure that they have adequate access to PPE. Do you have a plan for remote-only counties? And we're going to talk about that a little bit more to come, but some providers, some TCM providers might choose to share monitoring responsibilities if they've got staff who have a compromised health. So some might be doing the documentation visit and the remote visit, the virtual visit, home tour of the home, while others go out into the field. So what is your plan? How are you planning to deal with that? Conducting virtual visits, just a plan for what the expectation is, that you're going to be seeing all that you need to see and making sure that all of your monitoring components are conducted. Conducting an in-home visit, risk mitigation strategies. If you're going out and traveling into a county, if you're having to go out into a county that has remote-only access, make sure that you are taking a cooler with you, that you have your snacks and drinks or a lunch with you, so you don't have to stop at convenience stores or whatever to get a drink or your lunch. Make sure your car is filled up with gas, so you're just making as minimal stops in the community as possible. Exposure notification. So if you meet with a staff or an individual that you find out has an exposure, or if you become COVID positive and you may have exposed people, be sure that you're notifying your administration and staff on how to, that has occurred so that they can take proper action. And then just staff training on how to be prepared and how to complete all of these functions that are expected under the new environment. Stay on top of emerging practices and make sure that your guidance is updated as those things change and emerge. So what we have done at Central Office to help support service and TCM providers in their planning to return to the community is that we have a Central Office team that reviews local, county, and state data on a daily basis. And then based on that data and that review, they have developed a list of counties that they have deemed as remote only. That list can be found on our DD website's COVID page under county status. There's a county status button there, and you can monitor to see where you're at. You know that if your county is on that list, that you have a higher prevalence of cases out there in the county, and so your risk mitigation strategies need to be heightened. It's not to say that you cannot go out into the county. We know that we as individuals living in those counties are still going to grocery stores and still going to get our medications at the pharmacy. Most of us are probably hitting a drive-through restaurant rather than going in and sitting down. But all of those are points of contact for exposure. So we are not immune from the exposure. We just have to work around ways to really mitigate that risk as we're going about our business in the county. So the factors that we take into consideration when determining if a county goes on this remote-only status is the total number of cases in the county. We're looking at the 1-day, 7-day, and 14-day case increases as well as the percentage increases. So we're looking to see if they're going up or if they're coming down, and we're able to project out based on 1-day, 7-day, and 14 days. The total rate per 100,000 in the population. So that equalizes the prevalence based on the population of the county. The rate per 100,000 in the last 14 days and the percent of cases in the last 14 days. Hospital capacity is a consideration across the state, but our rural areas we know are more at risk for that real surge. And then local information. Sometimes we're getting local information. We have fusion calls throughout the week where there are representatives from all departments and even local entities and healthcare systems that are on those calls. And so some of the local information that we know, but we also depend on our providers out there to let us know if they're hearing about things that are going on locally. So you don't need to worry about, reporting to us what these trends are for a 1-day, 7-day, or 14-day trends. But what we need to know is, was a preschool shut down because there was an outbreak of the coronavirus, or was there some change within the school that in a response to the coronavirus or something? Those are things that we might not know about. An example of something that we learned that influenced our decision to put a county on a remote-only status was a church revival that happened. Lots of singing, lots of people gathered, and we know that singing really propels the spray and droplets, and sure enough, a week or 2 weeks later, we had a significant outbreak in that county. So those are the local kinds of things that we could really use your help with staying on top of. And when you come to know those things, you can send that information to ddmail@dmh.mo.gov, and we will be sure that that gets routed to the proper person to consider that with all the other data. Val Hoon, our division director, is the one that has the authority to say this is a remote-only county. And so we're asking everybody, if you have concerns, that if you're not in a remote-only county, talk with your TCM TAC, talk with someone at the regional center, call central office just to kind of talk through your concerns about your status and what you can do to help mitigate any risk. Certainly, if there are any state or local health or city ordinances that have been put in place that are more restrictive than what DMH has guidance on, those ordinances and rules supersede what the department has put in place. So you will always take that into consideration. And with that, I'm going to hand it over to Carrie to talk about how to schedule in-person visits.
Good morning, everyone. So moving towards the in-person visits and how do we go about scheduling? We know that physically seeing the individual as well as monitoring seeing their physical environment is critical. And it is so important for support coordinators to be laying eyes on individuals. So as part of that planning, the support coordinator will call the home. They're going to review the pre-planning tool, and we will look at that in just a bit, but review the pre-planning questions to determine how the visit should occur. And that planning will include things like planning around inclement weather. I know that's been a question in the field. We're in the middle of summer, experiencing some days of really hot weather. So how do we deal with that? And we know that, it's all in the planning. Can we schedule a different day? Can we schedule those visits for very early in the morning or maybe later of an evening? It's not that we're not going to make the visit because it's too hot today when we had it scheduled, but really that critical piece of planning around how can we make this happen for the individual so that we can have that in-person monitoring. Of course, we know that planning is individualized. It varies for each individual, and the planning team will identify and address any concerns, any issues that come up for that individual to determine how to move forward for them. So now we're going to actually look at the pre-planning tool. This is Appendix A, Guide for Pre-Planning, and this updated version was posted just late yesterday, so hopefully you have seen that. It did go out in a DD notification. And it was posted with the guidance document, the return to in-person monitoring, which is what we're reviewing today. The pre-planning tool was also posted with the ISP planning, monitoring, and review guidance document located on the DD website. Both of these guidance documents do reference this tool, so it is located in both of those locations. So when we look at this pre-planning tool, these questions were put together, and you will see here there are 3 questions, starts with 3 questions on the tool. And the questions are to assist the support coordinator to determine when those case management services can be safely delivered in person. So this is a tool that should be used prior to each and every visit, and it is utilized for any setting where TCM services are provided. So this does include the family home. This is one of the revisions that was made to the tool. I know we had some questions. Is it only staff that we're focused on here? What about those individuals living in their natural homes or family homes? So you will see when we're looking at these 3 screening questions, it applies to individuals served, also looking at staff, family members, and any roommates that would be in the home as well. So these 3 questions are really to determine the exposure status in that individual's home. So is there anyone in that home that is positive for COVID? Is there anyone within the home who is awaiting a COVID test? Or is there anyone in the home who is currently experiencing those symptoms? And if you look at the Appendix A, that guide and tool for pre-planning, it does include symptoms that you can go down through and review. And if anyone is experiencing any of those symptoms, then the visit should not be scheduled. So as the support coordinator is going through, they're going to screen, they're going to answer those 3 questions. And if the support coordinator answers yes to any of the questions above, then that visit may be postponed until 14 days post-diagnosis and 24 hours symptoms-free. However, if there is a concern for health, safety, or welfare of anyone within the home, then that in-person visit is required. If we look at that guide continues, and so if we look at that, there are some additional questions. If any of the 3 are answered as a yes, just some additional information gathering. So has the individual, did they contact their primary care physician to report this? Are they currently utilizing Station MD? Are they seeking testing? And do they receive assistance in order to complete any of these activities? If they need that assistance, that's where the support coordinator then would facilitate support and would assist the individual to identify someone who could help them. There are also some questions specifically for the staff, family member, and roommate, if any of those questions are answered as yes. So if it's a staff, family member in the home, are they currently working? Were they sent home? Are they currently getting tested? And if it is a staff member who is in that service setting, who else have they been in contact with? We then move on. There are questions then 4 through 9 within the checklist. And these additional questions would be if the support coordinator is screening by that question 1 through 3. If all the answers for questions 1 through 3 are no, then the support coordinator has some additional questions there that will just assist them with the planning for that visit. It's not about additional questions to screen out doing the in-person, but it's simply to assist them with now how am I going to move forward to make this in-person visit happen. So questions like, okay, where are we going to meet for that visit? Where is a safe place for the individual and I to meet for our visit? So maybe out on the patio, a front porch, maybe through a window, but where is that location? And then questions for planning such as, will the individual wear a mask? Will they follow the distancing in terms of the 6 feet? Will they follow that guidance? And if not, again, what are we going to put into place then to mitigate that risk there? So maybe looking at monitoring through a screen where the support coordinator is at least 6 feet away and they're wearing that face covering. There's also a place where concerns, can be noted in terms of the open air visits that are brought up or indicated by the person, family, and or the staff, and how that is being resolved. So again, not a reason not to make the visit, but yes, we know there are concerns, and this is what we're putting into place now moving forward to address those concerns. And then also for consideration, required paperwork. Is that something that the support coordinator can receive and can review electronically, or is that something as part of that monitoring visit, are they going to be physically picking up hard copies of that paperwork? And if so, how is that going to work? How are they going to collect that information? And so that is our pre-planning checklist. And Wendy, I don't know if you wanted to say anything in terms of revising the tool.
Yeah, Carrie, thanks. We've had several questions about the ability to modify the tool or add things to it. And so here's what I would say is that if you want to add things to the tool, especially the bottom portion of the tool, that are going to help you be prepared for that visit, certainly go ahead and do it. The criteria at the top that is being used to determine whether to do a visit or what kind of visit to do, that we can't change. We need to know that we are implementing our case management monitoring service consistently statewide, so we all have to use the same criteria in order to provide that monitoring. So that top portion can't be changed, but if you want to add some items to the bottom, you can. One thing to consider is that if you do that, is that this is not designed to be an official record. So this isn't going to serve as documentation for the visit or for anything. It is just to help you prepare for that visit. So as you modify it, or if you add things to it, you need to ask yourself, what are you going to do, or what do you need to do with the answers to these questions? Should it be something that's really documented in the support coordinator monitoring log, or is it really just for planning purposes and you put it on this tool? So I would just say to keep that in mind and be mindful that you're not using this tool or this document as a source of as an official record, because that's not its intent. So as we go from the planning phase, we need to move back into actually conducting the visit. We have some different, about 4 different types of visits that are going to be options that you select when you do your recording of the type of visit. So right now we know we have a phone-only visit for people who don't have access to a video camera, or there is a virtual visit for people who do have the technology for having a video visit, and then what we're calling an open-air, in-person open-air visit, and then an in-home visit. So in an open-air visit, there's basically 2 types. There's inside-outside. So the individual stays inside the house. The support coordinator is outside the house. You might be talking through a screen. You could be talking through a closed window or a closed patio door with the person on the phone. You might be in a multi-story building, an apartment on an upper floor that you can't talk through a window, or there's no exterior door access. So then you need to plan with that provider about how can you conduct that visit. Maybe there's a way to hang a clear shower curtain over the door of the apartment so that the support coordinator can be on one side and visually see the individual and even parts of the apartment and do that in-person visit. I know that we have had people talk about and have concerns about staff ratios. And so if people we know that providers are struggling to recruit staff and to maintain staff, and that they're working long hours, and sometimes their staff are sick and not well. So staffing ratios could be of a concern. So if this would definitely be a time to do an inside-outside visit, because it can maintain the staffing ratios and keep people safe inside, especially if the individual is concerned to be maybe an elopement risk, that you can't have a staff then following someone through the neighborhood and trying to return them home if you have staffing concerns inside. And then sometimes people have brought up concerns about Hipaa issues. So if you're outside talking with the staff or an individual through a door at a 6-foot distance, and you have neighbors in close proximity, you have to be mindful of the conversations that you're having and not breach any Hipaa rules. And so if that is a concern, that too would be a time to use the phone, to have the conversation over the phone, and then be able to see people visually either through an open or a closed window or door. The outside visit is where both parties, both the support coordinator and the individual, are outside, maybe on the deck, maybe in the backyard, maybe on the patio out front. Things to consider. In both cases, you're going to want to have PPE, and you're going to be wearing a face covering. You might consider, based on the type of individuals, support needs, what kind of PPE you might need if you're doing an outside visit. Things to consider there too is their ability to social distance, their cooperation or ability to wear a face covering. If those are of issue and concern, then maybe an outside visit isn't the best option, and you should do the outside visit instead of both of you being outside. So again, these are things that you just have to work through, know what's going on with the individual, how they are reacting to the social distancing and wearing face coverings. This is what makes it impossible for the division to really dictate how those visits need to be handled, and in every situation do this, because each situation is going to be unique based on the individual, based on the home, and how you're able to actually see the person in whatever kind of home that they're living in. In either case, whether you're doing an in-person visit where the individual is staying inside the home or whether they're joining you outside the home, you're going to have to complete the rest of your monitoring through a virtual visit in order to see the home and all the other pieces of monitoring that you would do if it were 7 months ago and you were visiting people in their home. So you're going to need to be able to do that virtual visit. And we have put out guidance that effective September 1, all service providers have to have the ability to do a virtual visit. It doesn't matter if it is with a smartphone or a tablet, or if they've got laptops in the home that have cameras on them, whatever mechanism that they have is fine. And now is a good time, actually, to build that capacity, because you can purchase those items and turn them in on the CARES Act funding. That would be covered under the CARES Act funding. I also know that if you are a MARF provider, that that technology can be acquired for medical reasons to help with the telehealth medical visits. But if one of those items that you're getting is the tablet or whatever, so that they can do the virtual visit with the doctor, it's going to work for this purpose as well, because it is the communication between the individual and the support coordinator. So it is to facilitate the individual's visit with their support coordinator. So that would also be an acceptable use of that. What you're needing to do is, again, tour the home, make sure that it's in good repair. I ask that DSPs and talk with the DSPs. Don't be offended because I'm going to ask you to show me the bathroom floor, maybe around the toilet. You're looking for cleanliness. You're looking for, the indications that the home is being well maintained and is tidy and clean, and is a good environment for the individual. So it's not to offend anybody. It is just simply a part of the support coordinator's job, and we need people to just to understand that. and not be offended or put off by that. So conducting an in-home visit. Now, not everybody is ready for this, but we do have in some parts of our state where they are doing in-home visits, although they're limited. Last time I talked with them, they were just really stepping inside the front door into the foyer area or whatever, and wearing full PPE and talking with people in person. That way they can see more of the house and conduct, the visit and see more of the house that way, but they may still need to do a virtual visit to see everything that they need to see. So this is not mandated at this time. We're not saying that if you're in a county that's not remote only that you have to do an in-home visit. This needs to be done in cooperation with the provider or the family, whoever, is in the home. So it really needs to be a partnership that you guys have to agree that you're comfortable with it and that it's safe. So we're wanting to take this slow and letting everybody get comfortable with how to progress back into what will be our new normal. So you should be looking at, if you're in a really low prevalence county, that you have full PPE available, and consider a low-touch approach. That meaning that you go into the home and you're really not touching anything. So a good example is our licensing and certification unit. They are going in some homes if it's in cooperation with the provider, if they make that arrangement. But when they go into the home to do that part of their certification visit, they aren't touching. They're in full PPE, but they're not touching anything. So if they need to test the fire alarm, the staff is hitting the button to test the fire alarm, or opening a door, or doing whatever that they need to do. So they're going in physically to be present and to use their eyes, ears, and nose, but not to touch anything. The staff is doing that. So consider all those things as good risk mitigation efforts if and when we get to the point that this becomes a reasonable thing to do and people are ready to take that step. And so lastly, we have health and safety visits. And so if anybody has a concern over the health and safety of somebody in the home, a virtual visit is not going to be enough. We're going to have to get in the home and go and see the person in person. So I said in the home, if you can do it reasonably based on what is the concern, if it is the individual, abuse and neglect of the individual, and you can go and physically see the person through a glass door or a window or whatever, and see, look for bruises or injuries and those kinds of things, talk to the person, that is acceptable. If it is a concern over parts of the house that you can't see from a window or door, then you're going to have to do an in-home visit and check that out. Our investigators, if it is required for them to be able to see a part of the house or talk to someone, they are going in homes if it's necessary in order to complete their investigation. And likewise, so will other of our monitoring functions, our quality monitoring functions as well. We'll go in homes if need be in order to complete the tasks that they need to do. But our primary thing is we have to protect and ensure the health, safety, and welfare of the individuals we're seeing. So we need to be prepared to do whatever we need to do in order to make that happen. And if that means actually going in the home or going to do an in-person visit in a remote-only county, then that's what we need to do. There are safe ways to do an in-person visit in a remote-only county. If you're doing it through a closed window or a closed patio door or storm door and talking with people on the phone, there is no way for that virus to get through glass. You are safe. The individual in the house is safe. So there's a way to do those visits that can be done and protect everybody's interest. And so, again, depending upon what the concern is, you're going to have to problem solve on a case-by-case basis how you go about doing that. Let's see. And now as we get into talking about documentation, I'm going to let Carrie talk about that a little more depth.
Yes, so in terms of the documentation, the standard monitoring requirements are unchanged. We continue to follow the Division Directive 3.020, and so that includes things like the requirements for contact with the individual, requirements for monitoring of the environment, so monitoring to ensure that environment is safe, it's clean, the home is in good repair, and the documentation that comes from the service provider. So, for example, still reviewing the monthly nurses summary, the provider mental reports, all of those things that you were reviewing and monitoring prior to COVID, you are continuing to monitor and review those things. It just looks a little bit different in terms of how you're doing that. There is a new field that has been added into IQMFD, and this is for the support coordinator to enter the type of contact for each monitoring visit they make. The support coordinator will select a type of visit, and this is under a field called Communication in IQMFD. If the support coordinator goes out, they're completing their monitoring visit, and they don't identify any findings, then the support coordinator is going to enter that visit under in IQMFD and enter it as a positive outcome. And the reason that this is important is because central office then can monitor this transition as support coordinators are moving towards the in-person monitoring, can pull that information, pull that data, and monitor to see how we're making that transition. Also, in terms of the IQMFD database, currently working on an update in that IQMFD database so that the support coordinator can actually select more than one option. So as an example, let's say the support coordinator, they go out, they complete their monitoring visit, and they're doing an in-person open air, but at the same time, they're also doing the monitoring that's remote with video because they're doing that physical look, the review and monitoring of the home. So they're doing the remote with video. And so then in that situation, they could click on a box or select both of those options. So that should be coming in the future. The documentation requirements in terms of log note documentation, billing requirements, again, that is unchanged, as well as that requirement that the support coordinator must complete their ISP monitoring and review monthly or quarterly summary. So, you know, depending on that service that's being monitoring, if it's residential that's being monitored, then of course that summary would be completed on a monthly basis. So again, those are all documentation requirements. Were in place prior to COVID, and so those things will continue. For documentation that the support coordinator is completing for the in-person open air, just a reminder that that means the support coordinator is visually seeing that person. They visually are seeing, they're having that contact, but they are also speaking with that individual and or that individual staff. Okay, and I think that's it on documentation requirements, Wendy.
Thank you, Carrie. I just want to backtrack for just a minute to the health and safety visit. One point that I forgot to talk about is to explain that the reason that we're doing and identifying remote-only counties is not because you can't go out into the county safely and do your monitoring visit and that you need to shelter in place. That is not the reason. It is our effort to try to help reduce the footprint in those counties that are trying to bring an outbreak under control. And so essential employees in those counties are still going to work and doing their job. But what we're saying is in those remote-only counties, we're kind of giving permission to do remote-only visits, except in the cases of a concern for health, safety, or welfare of the individual, in an effort to help the county bring that outbreak under control. And so it's really just to reduce that footprint there. So I wanted to talk about that because it does sound counterintuitive sometimes about going out to do a visit if you're in a remote-only county. So I hope that helps people to understand why we're doing that. One of the things that I wanted to talk about in terms of documentation is that what we are going to want you to be observing and making notes on in your logs is observation of the provider's implementation of their practices around risk mitigation practices around COVID, or how they're responding to an outbreak, that if there are positive people in the home, that they're implementing their quarantine or isolation processes. Now, again, this is not going to look the same for every individual. Some homes, they're going to have people that feel really sick from it, and it may be very easy to have them quarantine in their bedroom and stay in their bedroom. Other people are not going to be compliant with that, and we can't shut and lock people in their bedrooms in order to quarantine. So quarantine is going to look different, or isolation is going to look different in each home based on how that home is set up. So again, you're going to have to know your provider, talk with them about what their process is, how they're making these allowances and how they're implementing that. If you have concerns about it, talk with them about it, talk with your supervisor about it. We can all consult on it. This is not intended to be an I gotcha, and you're not expected to be the authority or the end-all be-all expert on what that practice should look like. But does it make sense? Does it make sense for the individual? Does it make sense for the provider given the home situation? If it is a home that has bedrooms on two sides of the house and people can be separated that way and they'll stay separated, does that make sense? If you've got a house where everybody's sharing a bedroom and there's no way to really quarantine anybody into a bedroom, we have had providers that have moved people who were negative into a hotel while they maintain and care for people who are COVID positive in their home. So every situation is going to look different, and all we're asking is that you be looking for that reasonableness test. Does it make sense? And if it doesn't, let's have a conversation about it, because I know for a fact that everybody out there is wanting to do and intending to do the very best thing that they can for the individual, and nothing in this world right now is black and white, so we just need to talk about it. But what we need you to do is document clearly about what you're observing so that it supports those efforts. So just an example of what, I had a question pop up right in the middle of the screen there. An example of good documentation would be that you visited Sally at her home, the roommate is waiting results of the COVID test, and everyone in the home was wearing a mask, and they were using disposable tableware for meals. So those would be practices that provider would have put in place in response to an outbreak or a potential outbreak. So it's documenting that they're following their practices. That's what we're looking for. It doesn't do any good for a provider to have those practices in place if the staff don't follow those practices. And all providers and those management teams need our help as well, with our eyes out there to say, hey, yeah, they're doing a good job. They're following the practices that you have established, or you might need to spend some more time in training with these staff in this home. I think they need a refresher. So an example then, a non-example, of course, would be that I talked to Sally. She said she doesn't like to wear a mask, and so she's not. So, and again, that's a reminder, too, that all support coordinators should be working with the provider agencies and the teams to be updating everybody's individual support plan, to identify what things they need to be working on or what things need to be in place, protections and precautions need to be in place to help them mitigate risk with the COVID. If it's not safe for them to wear a mask because it may restrict their airflow too much and their oxygen drops, or that they would just not leave it on, then that needs to be documented, you know, in their plan that you're working on a goal to help them tolerate wearing a mask or social distancing or whatever that case may be. You're also going to find that there's going to be some missing documents, that the provider's not going to have certain things on hand if they can't get to the doctor to do their annual physicals or dental exams and lab work are the most readily identifiable documents that you could expect to be missing. Doctor's offices closed to well health visits, and some of them may not even be taking well health visits now. So those documents are going to be out of date. So again, we're not here to hold that against the provider. That was out of their control. But what you're looking for is, okay, what are they doing now? Do they have appointments made? Is the doctor's office open to well checks? Does the doctor feel that maybe they're open, but because this individual has some serious underlying health conditions, they don't feel that it's safe for them to come into the office for a physical when it's just not worth taking that risk and possibly exposing them. So the doctor may say, no, we don't think you should come in for the physical. So then can they do the physical through telehealth with the doctor? Will they agree to do that? Or Station MD will do telehealth physical, so you can always fall back to Station MD. The doctor may say, go ahead and get the lab work drawn because I know that the lab is really doing a good job of controlling and sanitizing and all that. So if you consult with your doctor about what is appropriate for the individual and when they can get these types of procedures done. If they were supposed to have a quarterly podiatry visit, but that's not considered to be advisable at this point, document what the doctor said. We're not asking support coordinators and providers to make that decision on their own and independently. Reach out to their primary care doctor, make those calls, ask those questions. If you can't get a hold of the primary care doctor, call Station MD and get their advice and document what efforts we're taking or what information and guidance that has been given to us that justifies why it's okay that these documents are not current. So again, here's a couple examples of how to write that documentation and a non-example of what is just insufficient documentation. We're not here to be an I gotcha or to call people out or find people that are out of compliance, but really to help them and work towards, okay, how do we get comfortable with getting back in rhythm with this stuff?
So using the in-person visit, so what if the support coordinator, they're doing their pre-planning, they're going through those questions on their tool, they are attempting to schedule that visit, and there's a refusal, either from the individual, from the staff. How is that documented? The support coordinator needs to make sure that they're documenting the reason for that refusal, any kind of efforts that they're working on to resolve the issue or to resolve any concerns, and make sure that they're working, of course, within that planning team to problem solve in terms of how can we move forward and how can we make this happen. So you will see here a couple of examples. The first example would be an acceptable example for how that would be documented. So it states that the house staff refused the in-person monitoring visit, and they state individuals are high risk due to underlying health conditions. So we see that they have documented there who is doing that refusing and the why. It's because the concern is that individuals are at high risk. Documenting that the county is not remote only, because we know if the county were remote only, then that monitoring would look different. Also then talks about those follow-up efforts that the support coordinator is going to put into place to resolve those issues. So they're going to contact the house manager to discuss safety precautions with community RN in order then to do an in-person visit next month. Then, of course, as the support coordinator takes those next steps, they will want to document those steps as well. So, you know, once they contact that house manager, they come up with a plan, they're going to want to document that who, what, when, where, and why as well. The next here would be insufficient documentation, and it just states that staff will not bring Betty to the window for monitoring visit. We'll try again next month. So that documentation does not outline why. What is the concern? Why will they not bring Betty to the window? And then what kind of attempts, how are they working with that team? What truly is the issue, and what kind of steps are they taking to move forward to resolve this so that they can do that in-person monitoring? I think we're ready for the next slide. So this is shared monitoring responsibilities, and Wendy spoke to this a little bit earlier in the presentation, that there might be times under our current conditions where support coordinators, more than one support coordinator, would be completing monitoring activities for a particular individual. So support coordinators can share those monitoring responsibilities. However, what we have to keep in mind is that each support coordinator must clearly document their specific monitoring activities in order to ensure there is no duplication. Of course, cannot have that duplication of the TCM billable activities. So that's really what you need to be looking for. So as you can see below, there are examples here. And this example outlines when two different support coordinators would be completing monitoring, TCM billable monitoring activities for the same individual. What might that look like? So you can see in this example, there is a support coordinator 1 and there's a support coordinator 2. So support coordinator 1, let's say they are the support coordinator who is assigned to that individual. They may be looking at documentation. So they may be doing things like reviewing the progress notes, reviewing any kind of the medical kinds of documentation, and maybe doing that virtual tour through the video monitoring to monitor the health and safety, you know, truly looking at that environment, and then documenting that, yes, it looked clean, it looked well maintained. You know, they didn't observe anything like, as they look through the front door, there's a huge hole in the living room floor. It looked clean and it looked well maintained. Also documenting what else did they physically see as they were going through and completing that virtual tour. In this example, they saw the refrigerator, pantry, so it looks like the individual does have adequate food. And they did observe that there was PPE on hand and it appeared adequate. In this example, the second support coordinator then might be the support coordinator that they're the support coordinator who can actually physically go in and lay eyes on that person. In this example, the first support coordinator couldn't do that. Maybe they were in that remote-only county, and so the agency's bringing in that second support coordinator to be the support coordinator who will lay eyes on that individual through that in-person monitoring. So with this example, that second support coordinator is actually going to visit with the individual at their home, and all members of the home, it states that they looked healthy. It talks about that they talked with the individual, so there's that, you know, they actually laid eyes on, they observed the individual, and they had that interaction. They talked with Sally. It documents where they had that interaction, where they had that monitoring, that open air, in-person open air monitoring. So they actually talked with Sally, met with her on the back deck. All parties wore face coverings, and they did remain socially distant. And then it talks about Sally's demeanor. I mean, they visually saw her, they interacted with Sally. So what was her demeanor? What specifically did that support coordinator talk about with Sally, and what did they observe? You know, what did Sally tell them? Were there any visible signs of injury, et cetera? So that just gives you one example of how, if you do have two support coordinators that are completing those monitoring activities, how that billing might look. And again, what's important is just to ensure that there's no duplication. It doesn't look like two different people are doing, you know, exactly the same thing, same day, same time. Really distinguish specifically how that TCM billable activity is different. They're truly doing different activities. And the next slide then, this is the TCM TAC review process, and just wanted to speak to, with all the guidance that's out there, what does that process look like and how will that be impacted by the guidance? We had already talked about earlier that from a support coordinator's perspective, they're going to monitor what they were previously monitoring prior to COVID. So it's following that guidance in Division Directive 3.020, which is our individual support plan monitoring and review directive. TACs will also be following that guidance. So that will include a review to ensure the frequency of monitoring occurs, and we know that that frequency is based on the service. So should they be making that contact monthly? Of course, if it's residential, we know that's monthly, or is that a quarterly contact? Also, the TACs will be looking to ensure that documentation requirements are met. So again, nothing new or different there. The logging billing requirements, that they continue to be met, and that requirement for completing the ISP monitoring and review monthly quarterly summary that's in place per that Division Directive 3.020. TACs will review to ensure that the type of visit is documented, and now, as we talked about, it has been added into IQMFD. So when they enter that into IQMFD, one of the fields will be to, you know, select that communication. And also, the method of contact, it was also part of the ISP monitoring and review monthly quarterly summary. So the support coordinator, it was always a requirement to indicate on that documentation, what's the method of contact? Was it phone or was it face-to-face? And we've just simply expanded that in the world that we're in now with remote and with video. We've expanded those options. So TACs will be looking to ensure that is documented. However, what they will not be doing is entering findings into IQMFD for the type of visit which the support coordinator documents. So for example, if the TCM TAC is out and they're completing an annual review, they are reviewing for a particular individual over a particular period of time for that annual review. They are not going to try to determine on, you know, August 12th, what visit should have occurred. Should it have been an in-person open air? Should it have been an in-person in-home? TACs will not be trying to determine to that level, and they will not be entering that into IQMFD. That is, as we know, it changes by the moment. It is very individualized, and that is the planning team to work out, because we do know that that changes. So they will simply be looking to see, yeah, it's documented, that method of contact or communication, but they would not be entering findings to try to determine on any particular date what visit should have occurred.
Carrie, I would just like to add that what we will be doing at the central office level is reviewing reports pulled from the IQMFD around the types of visits that are conducting, so that we can kind of monitor how the transition is going to in-person visits and how the transition is going to virtual visits. And so, and then working with agencies or TCM agencies or the TACs about how we help some people over the hump if we're having difficulty in making that transition. So those kinds of, there will be reports pulled from IQMFD so that we can monitor that transition. If you're wondering why we have to go through and monitor, or write all that stuff or enter all that stuff into IQMFD, if the tax aren't reporting on it, it's for monitoring from central office. So thank you. And I think now we're just ready for any questions that might have come up over the course. And I see that we do have some questions in the chat box. Heike, did you want me to just go through those, or did you have them any lined out?
We were scheduled from 9 to 10. I guess that depends on how long folks want to hang on the line. Don't have a problem with that. We do have quite a few questions that came in. I'm not sure that even if we stay on that we'll be able to get through all of them. So I'm happy to go through and pull a few of those out, or if you feel like there are some that you are better answered as you do a quick review and while we're live, I'm good either way.
Well, in interest of everybody's time, can we just answer the questions and post them with the webinar?
Absolutely. So what we can do is, I know I've had a couple folks ask if this recording will be available. We'll be able to have the recording and the transcript, which is a new feature for us, available later today and posted no later than tomorrow. So don't be surprised if those become available before the Q&A document is, but we'll also push out an email blast letting you know when the Q&A document is available as well.
Thank you very, very much to all those who have joined the call. We look forward to your questions and just learning from you and working with you through the process as we find our way forward. So thank you. Be safe.